It gives you a euphoric rush. It's like your whole body tingles all over the place, and it's a good feeling, happy, giddy. But then when you come down off of it, then people start wanting more, and they go crazy, and that's when they lose themselves.
What sort of changes do you notice have taken place with you because of your meth use?
It was like the whole world changed on me. Everybody, all my friends, everything. You know, maybe the invasion of the body snatchers, you know.
Are they doing meth too? Is that what you're talking about? Or?
Yeah, it's just, yeah. And even, I don't have nobody. Like, I'm a mom.
You see changes with people, especially if they're using methamphetamine, that has a distinct deteriorating effect on somebody's physical appearance. One of the faces that really stood out to me, and she was quite visibly intoxicated by methamphetamine. She looked horrible. She looked at least 20 years older than she was. Her teeth were missing, and I looked back in her history, and at one time, she was a fairly attractive young woman. Over a 10, 15, 20-year period, and see how they've deteriorated, how they've changed. Some were quite attractive when they began to come to jail. Young people who were...
Hi everyone, welcome to Hub Bites. I'm Sunil Regge, consultant psychiatrist. Today I'll be taking you through Methamphetamine Associated Psychosis, MAP. Now, this is a really important topic overall, as we know that the use of ice or methamphetamine, crystal meth as it's called, has become quite prominent, and it's a highly addictive substance as well. So I'm going to be focusing on its effects related to psychosis and some aspects as to how we can differentiate it from a primary illness such as schizophrenia. And I'll also be talking about some of the other effects that can be associated with it briefly. So let's jump into it and check it out. Now, methamphetamine use has been portrayed in a few films that I can think of. These are some of the movies that really kind of stayed with me. And of course, Trainspotting was one. Then we had Requiem for a Dream, and that was really harrowing. Really showed the ills of drug addiction. And the last one, as you can see here at the bottom, is Spun. So recent years have seen a dramatic increase in the use of crystal meth use, as I mentioned, particularly in this crystalline form, which is why it's called crystal meth. And advances in this meth processing has resulted in a drug that is now has a higher average purity, increased from 21% to 64%, and therefore a higher potency. This increase in purity and potency has resulted in increased price as well. So there's lots of economic incentives. However, the average purity adjusted price per gram has climbed. Now, taken together, these increases in purity and potency, as well as its favorable pricing, means that it's really challenging in controlling people's consumption of this really dangerous substance. So what is the molecular action of methamphetamine? If we think about methamphetamine, it is the most powerful dopamine releaser known to mankind in a way, because it not only releases dopamine through one mechanism, but it has this Lollapalooza effect of cumulative effect of a few things coming together for this rapid release of dopamine. And that's responsible for the range of effects, the positive effects that people experience, the euphoria, but can also result in that aggression and agitation. And in some cases, we know we'll be talking about psychosis, but then the physical effects and the actual impact on the brain as well through the extreme excitotoxicity. So what we can see here is it is a competitive inhibitor of DAT. Now, DAT is dopamine transporter, which basically means that it will take dopamine in here and package it into the vesicles. So that's dopamine, that's the function of the dopamine transporter. And this is the presynaptic neuron, this is the synaptic cleft, and the postsynaptic neuron will be here. So when dopamine is released, it will act on these postsynaptic receptors here. Now, you can see here, it is a competitive inhibitor of DAT, so it will actually block DAT at this point, which means that no dopamine will be taken in, and therefore loads of dopamine will be available here. But at the same time, it also is a competitive inhibitor at VMAT, a vesicular monoamine transporter, which basically packages dopamine into the vesicles. So it actually prevents that from happening as well. So there'll be loads of dopamine here. So you get this double whammy effect at this stage. We'll see what happens next. So instead of being packaged into a vesicle, there's loads available here and in the synaptic cleft as well. Then what happens is at high levels, methamphetamine will really displace out and force itself out into the synaptic cleft. So you can see at a critical cytoplasmic concentration of dopamine, it is released into the synaptic cleft via the reversal of DAT. So there is a third component, the reversal of DAT. And this results in a rapid expulsion of dopamine, and that's what's responsible for that euphoric effect. But along with it comes those other things which we'll talk about as well. Now, a range of psychotic phenomenon has been associated with methamphetamine use, from transient psychotic episodes during periods of intoxication to more persistent syndromes that resemble schizophreniform psychosis. Now, I've seen a range of clinical presentations, and some of them have been the most extreme form of aggression I have really ever witnessed. When that psychosis is resolved, the individual not having any memory of it, and the personality of the individual being completely different to that aggressive individual. So a very, very dangerous substance. Now, psychotic features with methamphetamine use have a prevalence of about 15 to 30% in recreational settings and less than 60% in some inpatient settings. Now, risk factors include how long the person's using it, but there are some genetic vulnerabilities as well. So some individuals with certain genetic aspects will have a greater vulnerability towards developing psychosis. So what are the risk factors? There's strong evidence of chronicity. The longer you use it, both in frequency and dose amount, duration as well, will be associated with greater risk of MAP. Family history of schizophrenia, bipolar, so a genetic vulnerability will increase the risk. And a history of childhood trauma, with one study showing that people with 3 or more types of adverse childhood experiences had a 4.5 times higher odds of reporting a MAP disorder, so methamphetamine-induced psychotic disorder. So what are the psychotic symptoms that we see? Commonly associated with hallucinations and paranoid delusions, which are not too dissimilar from acute psychosis in cases of schizophrenia. So very similar to acute psychosis in schizophrenia, hallucinations and delusions, along with disorganized speech, disorganized thought processes. But there might be some additional pointers. Now, in clinical practice, it's not that easy in the acute stages to differentiate whether this is actually schizophrenia or whether it's methamphetamine-induced psychosis. It takes a while to figure it out. We need to establish temporality, what came first, and then we focus on the nature of the psychosis as well to give us some clues, and we'll see what that is. Plus our long-term memory, implicit memory, explicit memory, etc. If you're looking to learn more about this topic and discover a range of other stimulating psychiatry courses, then don't forget to subscribe to the Academy by PsychScene. Now, what we do know is that visual and tactile hallucinations, visual hallucinations, seeing things, tactile touch, hallucinations of touch, and the most common thing that we find is what we call formication. It's also known as Ekbom's syndrome, the sensation of insects crawling under the skin. Often when we see them in clinical practice, they're often picking at their skin as well continuously. More reported to be common in MAP rather than other psychosis. And the presence of negative symptoms or first-rank symptoms are more likely to correlate with a persistent type of psychosis. So first-rank symptoms are basically the Schneiderian first-rank symptoms that point more towards schizophrenia. And these include the persecutory delusions, delusional percept, had a perception and it's been misinterpreted and a delusion has been formed. So I've seen this red car and now I believe that the mafia is following me, for example, or my phone is bugged, etc. Then it has passivity phenomenon, delusions of control, where they believe that something or someone is able to control their actions, their feelings, and their impulses. Then there is the thought interference, thoughts being put into the mind, taken out of the mind, being broadcasted. So these are some of the Schneiderian symptoms. In terms of hallucinations, there's often running commentary, hallucinations on their actions. Third-person hallucinations can be there, where two voices are arguing or discussing the person about the individual amongst themselves. So these are some of the Schneiderian first-rank symptoms. Again, on PsychScene Hub, I've put down first-rank symptoms. That resembles primary psychotic disorders such as schizophrenia or bipolar. So that's what we're looking for in differentiation clinically. Now, long-term effects, we know depression, anxiety, psychosis, chronic sleep disturbances, but neurocognitive effects are prominent because of this excessive dopamine release, excitotoxicity, which can result in apoptosis, really bursting of cells. And I've seen scans, for example, MRI scans with lots of white matter hyperintensities as a result of chronic methamphetamine use. And prefrontal cortex can be affected, so it can affect executive function, selective attention, episodic memory. All of these overall neurocognitive impairment can occur. We also, during examination, can see individuals with tremors, cogwheel rigidity, so almost a subcortical involvement that can occur. Similar sort of things can occur in early stages of Parkinson's disease, because subcortical areas means that the basal ganglia areas are affected. Weight loss, dehydration, poor appetite, hypertension, renal failure. And it's not uncommon, as we know. Poor dentition can occur. This really dry mouth over extended periods can result in dental caries, and skin picking, as I mentioned, that can be quite severe in certain individuals. Now, a recently published study, and this is by Dr. Shalini Arunagiri and Professor Rebecca McKetton. Now, we have Professor Rebecca McKetton, who's an expert in MAP and methamphetamine in general, and she has a number of talks on our channel. So do have a listen to them if you want to know more about the effects on the brain.
With repeated use over time and very heavy use, this is what happens. You just feel like you need to have ice to function. I couldn't get out of bed without a smoke of ice. My life evolved around this pipe. I'd clean it, I'd go crazy if someone touched it. The come downs were just disgusting. The paranoia, hearing things, a delusional state. Just thinking about where my next hit of ice was going to come from. So you can see here in a healthy person, you've got lots of dopamine binding shown by the red and the yellow here. But in someone who's stopped using meth, the downregulation in those dopamine receptors is evident by the lack of red shown here. And that what I just described to you is what that person will be feeling like. And it does recover, but it takes some time to recover, so that's 14 months later.
What the studies have shown is there are different subsets, and these are differentiated by the symptom patterns, which has been suggested to identify whether an individual will progress to psychosis. Type 1 is the most prevalent. 43% of the population studied, with a high degree of persecutory delusions, someone's following me, my phone's being bugged, etc., but with smaller probability for hallucinations of first-rank symptoms. Type 2, 35%, and these subjects also experienced the same types of delusions as this, persecutory delusions, but that they were more likely to experience hallucinations. And then type 3, this is only 22%, but these subjects showed similar symptoms as type 2, but they had a higher probability of Schneiderian first-rank symptoms as well as delusional symptoms. And you wonder whether this third group's Schneiderian first-rank symptoms means that more possibility of this chronic, schizophreniform psychosis that's possibly present. So this is the spectrum. In terms of treatment, I haven't gone into too much detail because treatment's a challenging aspect. We need good drug and alcohol services input, whether that's inpatient detoxification, follow-up. All of those aspects are really important. Motivational interviewing, motivational enhancement therapy. But there are a few trials going on, and at least in Australia, there might be other trials elsewhere, but lisdexamfetamine, which is a stimulant, as we know in ADHD, is being trialed, and safety has already been established in phase 2 study at higher doses. So we wait to see what are the results with lisdexamfetamine for methamphetamine addiction. There is what's known as MAT, the psychological approach of methamphetamine approach avoidance therapy. Then mirtazapine is being trialed for meth addiction as well. We're waiting for the results there. So there's a few things happening here. It'll be interesting to see what the results are. It'd be great to have a treatment that actually helps individuals with this really, really terrible substance addiction. So I hope this gives you an overview. If you liked this video, give us a like, subscribe to our channel. Let me know what other aspects you'd like me to cover as well. And I really appreciate you giving up your time to watch this video. I look forward to seeing you in another edition of Hub Bites. Take care and stay safe. Bye-bye. Synthesizing complex material in psychiatry to simplify your practice.